Well, thank you so much, Molly, and thank you guys all for coming today. I'm really excited to see so many of you. As Molly said, I am Eliza Eaton. I am the Autism Community Engagement Coordinator for AIMS2 Trials, based out of the Autism Research Center at the University of Cambridge. And I am really excited to talk to you all today about the language guidelines and glossary that we've developed in conjunction with our fantastic AREPs. It's our hope today that we can help you develop a deeper understanding of the meanings and the mindset of community preferred language, especially in the biomedical research context. And then we also want to provide some further avenues for learning when and if you have the time and the inclination to go deeper. So before we do that, just a quick thank you, first of all, to the AREPs who gave their input. Could literally not have done any of this without you. So Dave, Eleonora, Pierre, Sarah, Katrine, Mary, just again, you guys know how much I appreciate you, but I will say it again and again until you get sick of hearing it. Additional thanks to research and science communicators from the various parts of our team who provided consultation on the recommendations. So that would be Shifra, Matt Castle, Rosie Holt, and Tracy Parsons. And then, of course, I do want to just put in a plug for our further reading and our works consulted. This is at the end of the slideshow, but of course we do have this as a glossary, and all of the recommendations are available kind of as a PDF. If you just send me an email, let me know, or I guess send Molly an email and let her know. You know, we're happy to share with whoever wants it. So with that in mind, before we get started, it's really important to note that because preferences in terminology differ between members of the autism community depending on a lot of things, for example, context that you're talking in, culture, we recommend that whatever you do, your first consideration should always be the preference of the autistic person that you're talking to. So, you know, there are a lot of things that that might differ from person to person for a variety of reasons. And if you were talking with an autistic person, please, please, please default to whatever their preference is. If they tell you they prefer to be referred to as an autistic person, use that. If they prefer to be referred to as a person with autism, use that. If you're not autistic, please don't correct the autistic person that you're talking to. That said, we feel confident with the recommendations that we're making because a number of terms have emerged that are generally widely preferred within the autism community. So the main goal of today's presentation is to explain the terms that we are recommending that you use and to empower you as a researcher to make informed choices about whatever language that you use in the various contexts that you talk about and write about autism. Why use community preferred terminology in the first place? The terms that you've been using for your whole career, and you're very obviously good at your job and you know, you're successful. Why use these terms at all? Well, the three main reasons that I kind of think of might surprise you a little bit because it's not really about a social or political statement. For me, the first reason is that the terminology that we're recommending, the currently used terminology, it functions as a descriptor of a shared experience. Autistic people, you know, obviously we have a lot that's different between us, but we have developed some terms that kind of mean the same thing within various cultures within the English-speaking world. And you know, when we say a certain thing, that term means something to us, and we want to make sure that we're not talking past each other, that we all are understanding exactly what we're meaning. So that's kind of the primary reason. We just want to make sure we're understood. The terms that we're recommending are also going to help you avoid some deficit thinking that presents some unspoken and largely negative assumptions about what it means to be autistic, most of which are kind of a matter of opinion rather than a matter of fact. And then finally, using community preferred terminology will help you set your research relationship with your collaborators, your partners, your participants off on the right foot from the beginning. We want to make sure that you're not kind of setting a relationship back before it's had the chance to get started. So with all of those three reasons in mind, I do also want to let you know, and this is really important, that no matter what terms you use, even if you are using all of the terms presented herein, you and your work are more likely to be judged as deceptive or inauthentic or untrustworthy by the community if you're using these terms while neglecting the really important and really long-term work of community engagement. Or if you are using these terms while also actively promoting research that doesn't engage authentically with community priorities. So it's really important that these terms are a starting point rather than an end point. We want to make sure that that you are not just kind of taking these and piecing out, that you're actually engaging and continuing to engage with the community. When in doubt, we want you to avoid any language that connotes a need for autism to be cured or implies that some autistic traits are better than others, especially if it is implied that a neurotypical brain and neurotypical traits are better, superior, more desirable than neurodivergent ones. That's kind of the recommendation at the heart of all of these terms. So the number one piece of feedback that I get, or bit of confusion that I get when I'm talking about these terms, is the idea that, well, I have done this a long time and I've heard those terms used differently. And my answer is usually, yeah, you probably have. Things change, and some of the terms within this resource are still actively a matter of either preference or disagreement within the community. And as I alluded to earlier, this can be true of things that even as basic as using the term autistic person versus person with autism. And of course, we do have more on identity first versus person first language in the resources in the appendix. Preferred terms also are going to differ between languages, between cultural contexts. And in fact, this resource was first developed to aid in translation, helping any of you who are working both in English and a different language, so that you can understand kind of not just the meaning of a term, but the context that it's usually used in. All of this is with the goal, again, of helping you make an informed choice about whatever it is you're using in whatever context. So whenever there's disagreement within any of these terms or about any of these terms, I'm going to make sure I make a note of that for you so that you can really understand what choices that you're making and why. All in all, I would encourage you to stay curious about the way that terms and language are used to describe autism and autistic people. And of course, please don't shy away from nuance, but also don't shy away from specificity. Say what you actually mean. And before you say it, take a beat to consider, is this actually what you're talking about? We'll talk a little bit more about what that might look like later in the presentation. So let's get started with some terms. The first term I want to highlight for you is neurodivergent. So when we're talking about any person or any mind that is different from the typically developing mind or person, we're talking about neurodivergence. This is going to hopefully replace terms like abnormal. So any language that implies value, one being kind of better than the other, or any language that is implying that autism is a medical problem. So if you're talking about your research, where if you were, researching, cancer, you might use, the term healthy controls. Of course, we know that neurodivergence is not medical. You can be perfectly healthy and be neurodivergent, or perfectly healthy and be autistic. So we want to make sure that that you're kind of just contrasting the two things you're really talking about, a neurodevelopmental, neurocognitive difference versus typically developing. Now, neurodiverse and neurodivergent are similar, they're connected, but they do have two kind of slightly different meanings. A person would be neurodivergent, would be a blanket term describing anyone who is not neurotypical. A group of people is almost always neurodiverse. Any group of multiple people with different neurotypes contained within it is going to be neurodiverse. So when you're talking about one person, neurodivergent. When you're talking about a group of people, neurodiverse. And again, there are some people who don't like this term used to describe themselves. And if they are letting you know that, by all means, listen to them. Don't continue to use something that somebody has told you they don't like to hear described of themselves. Getting a little bit more specific, we had neurodivergent, which covered ADHD, dyslexia, as well as autism. We're using the word non-autistic to describe anyone who is not autistic. And of course, there are many non-autistic people who are not neurotypical, but they're not autistic. So do understand that there's a difference between neurodivergent and autistic. There is a difference between non-autistic and neurotypical. Non-autistic is just somebody who isn't autistic. This word is what we're recommending because it conveys no additional information. The only thing that it will tell you if you're using it to describe somebody is that they are not autistic. Again, when you're talking about your research, these are going to replace things like normal or healthy. And of course, neurotypical and non-autistic are similar, but they don't mean the same thing. Be aware that you might sometimes see the word autistic used kind of in, synonymous with non-autistic. If you are familiar here in the UK with the comedian Fern Brady, her book uses the term autistic several times. That's my new go-to example for this term. It is fairly controversial. Some people use it, some people don't, some people kind of consider it offensive. I wanted to just flag it for you because it is something that you might see, but we are going to recommend just non-autistic rather than using autistic. Our next term that we wanted to flag for you guys is support. And in this situation, when we're talking about support, we're talking about using the word support when looking at the various different things that an individual might need in order to live the life that they want to live. These can include things like medicine. These can include things like interventions. But when we're talking about personalized or targeted support, the reason that we recommend using this, unless you are specifically talking about a pharmacological intervention, which might be medicine, the reason that we're recommending this is because it is free. The word support is free of the medicalized context that other terminology has. We don't want to imply that autism is a disease needing a cure. And so when we are talking about researching supports for autistic people, unless you are specifically talking about a compound that you're researching, I would keep it broad. Be specific when it's appropriate to be specific. But if it's not, please go more broad. And in this case, support is what we would recommend. We really want to open up your thinking about autistic needs and kind of have you guys consider that there are lots of needs that autistic people have that have nothing to do with medicine. Our next word that we wanted to flag for you guys is subgrouping, and this one especially, I'm sure you guys are aware, remains controversial. Because autism can look very different from person to person, because it involves a lot of different co-occurring conditions that will benefit from supports that are specific to those conditions. There are a lot of autistic people, many of whom are on this call today, who are actually in favor of looking at subgroups of autistic people and focusing on their needs. Examples of this, of course, would include autistic people who have epilepsy co-occurring, autistic people with ADHD, autistic people with sleep issues. These are all different subgroups of the broader group autistic people that would benefit from research specific to them. What we do not want is to imply that there are levels of autism, that there is a hierarchy of autism, kind of running from very, very, very high functioning and therefore more neurotypical and therefore more worthy, down to low functioning, severe and therefore less neurotypical and less worthy. It is inappropriate to kind of imply that even accidentally, and it is a source of mistrust between the autistic community and the biomedical community. There's a lot more on this kind of in our appendix around the eugenicist origins of autism research and why the autistic community is so wary when it comes to attempts to stratify autism. We really want you to think about what it is you're saying and why you are talking about subgrouping, so that you are not leaving your audience to wonder why you're talking about this. Because when left to fill in the blank, many people will jump to wanting to cure autism or implying that one type of one set of traits is better than another. Kind of coming on from that, high and low support needs. This is, as I know all of you are very well aware, a source of a lot of controversy in the field right now. The idea of high or low functioning autism, profound or mild autism, is an argument that I think we all know is going on. The recommendations that we would make are instead to use the phrase high and low support needs. So somebody would be described as having high or low support needs. And the reason for that, there are a few. So I think that if you're not aware, you should be, that the vast majority of autistic people will need support in some form at some point in their lives. And this can vary not just between autistic people, but also across a person's life. High and low functioning, profound and mild, these both imply that the way somebody's autism looks is a fixed and global state. It is going to be the same throughout their entire lives, and it cannot be changed, and it applies to everything within their lives. And once that label is there, it's there. It's really hard to shake, regardless of what circumstances are and regardless of how accurate it is. And it doesn't tend to be accurate. There are many autistic people who are, I would say the vast majority, who do not fit neatly into this functioning label paradigm. And it's often tied to IQ, unfortunately. And of course, we know that there are a lot of scientific issues with the way that we measure intelligence and IQ. Some autistic people will have persistently high support needs, either in one or two areas of their life, or who will have high support needs in all areas of their life for the rest of their lives. So, you do get people who have very high support needs in communication, but can be and are extremely independent with the correct support structures in place. And of course, For a lot of us, again, many of whom, myself included, are on the call today, have encountered situations or will encounter situations in their life where their support needs become extremely high, but have other parts of their lives where that's just not true. So when we use the phrase high and low support needs, it's not so much like the idea that somebody is low functioning feels offensive, although it might. It's more that we really want you to be accurate. We want you to accurately describe what we are experiencing. So we have more on functioning descriptors in the appendix, and more on kind of why we prefer using support descriptors instead. And of course, if you have any questions about that, we're happy to, I'm happy to go into detail about that later. Autism. This one, I think, is one that you all are well aware of. We generally prefer using the word autism rather than ASD. Autism is preferred, and it's even preferred over phrases like on the spectrum or ASC, autism spectrum conditions. Many surveys have shown in English, autism is the way that most autistic people prefer to describe the neurotype. There are lots of reasons for that, especially around the kind of implications of the word disorder. It implies that there is something inherently wrong and undesirable about being autistic, which is something a lot of us would dispute. That said, you know, condition still has some medicalized connotations that are not always applicable to autistic lives, and that's kind of why we prefer using autism whenever possible. And we know that there are some barriers to that in terms of journals, and we have some guides to help overcome that. We have some kind of resources that you can draw upon. But you know, please make sure this is what we are recommending, and we hope that that this can become kind of consistent in public-facing work that are associated with AIM2 trials. This is another one I think you guys have probably heard before, but I would be remiss if I didn't touch on it. The word likelihood, as in likelihood of autism or chance of autism, is very much preferred over the term risk. If what we are trying to describe is the probability of somebody being diagnosed with autism, you know, increased likelihood, decreased likelihood, these avoid a really kind of obviously negative word like, you know, like risk. It has that connotation of danger. You know, this is going to be something that implies something inherently negative. Nobody has ever, you know, talks about being at the risk of having a really nice day, right? Like it's just not a word we use to describe good or even neutral things. Whereas likelihood and chance, these are value neutral. You can have a chance of something positive happening to you just as much as you have a chance of something negative happening to you. So, you know, we would advise you default to either likelihood or chance when talking about this. Because of course, when you imply, you know, when you call it a risk of autism, it's going to imply that this is always going to be fully negative, and there's a lot of stigma that comes along with that we're really still trying to fight. That has a lot of really kind of nasty and dangerous consequences that we don't want to contribute to. Additional needs is something that, you know, we talk about a lot. The term special needs has been used in the past. And of course, our preference is for additional needs simply because the requirements for equipment, help, interventions that are enabling people to live the life that they want, these are not special. They are just additional to what other people might require. Special is kind of patronizing. It's something that an adult might say to a small child, and that's not appropriate when talking to other adults. It also carries the connotation that these needs might be extraordinary or burdensome, which is kind of, you know, it's an offensive and unpleasant thing to suggest, and it's also not always true. And of course, additional needs are not limited to neurodivergent people or to disabled people more generally. So there's no reason to frame it as special when they are occurring alongside an autism diagnosis. Everybody has needs, some of which are additional to what other people might require. And let's just kind of be value neutral about it. This is one that is a really important one for me to flag, because we have some terms within the community that when we use them, other autistic people are going to know exactly what we're talking about, but often neurotypical people they don't use them or are using kind of these terms that we're recommending that you avoid. And so there's a lot of kind of people talking past each other when it comes to these. So we have terms like challenging behavior, disruptive behavior, or problem behavior that show up in research. And what we would advise you doing is, instead of thinking about the way the behavior is perceived by observers, that would be challenging, disruptive, or problem, think really about what is going on with the behavior. There's a saying in in autism education that all behavior is communication. And thinking about what the behavior is communicating to the outside world rather than how other people perceive it is going to be very, very helpful in terms of describing it and measuring it more accurately. So we have distress behaviors like meltdowns and shutdowns, and then we have coping behaviors like stimming and soothing. And then we also have self-harming behaviors that can kind of fall under either either category. Meltdowns are the community preferred term for a behavior that is, or a set of behaviors that are uncontrollable and sometimes harmful to a person or other people, usually coming as the result of a really painful sensory overload. So meltdowns you can think of as an effort to push everything away so that your brain can get the quiet that it needs. Shutdowns are going to occur within a similar context. Again, painful sensory overload is going to be one of the things that is most common to bring them on. But in this case, it is the internal version of a meltdown. It shuts off all responses to the outside world to try to avoid further pain. So you have a meltdown is going to be something you see and you see really obviously, whereas a shutdown is going to be the opposite. You might not even notice that it's happening, but the autistic person experiencing it will definitely notice that it's happening. And then you also have coping behaviors. Stimming is what autistic people are going to refer to as kind of the repetitive behaviors that help them focus on specific activities. Some autistic people also lump soothing behaviors in with stimming. So a stimming can be something that you might use, to focus, or something that you might use to kind of keep yourself calm. Whereas other people distinguish between the two. These are usually harmless, even if they are kind of flashy or showy. So an example of this might be hand flapping, but also facial stims, which is something that I do quite a bit. That help me to either focus or to allow me to cope with stress. Removing value judgments like challenging, disruptive, or problem are going to be really, really important, both to lessening stigma and to accurate descriptions of these behaviors. It doesn't hurt anybody if I'm making the muscles in my face do a thing. It just might be distracting for some people, but if it helps me better do my job, it's really harmless. Now, are there some of these behaviors that might include self-harm? Absolutely. And it's really important to distinguish the behavior's purpose and what is going on, what the result of the behavior is, to try to make those connections between what's going on in the brain and how those behaviors can be helped if they are harmful. But again, some of them don't need to be helped. Some of them are harmless and are really helpful to the brain. All right, and we have two more before we finish, if that's okay, Molly. Our next one is strengths-led or neutral terminology. So this is one of the things that kind of like a category rather than a specific recommendation. Whenever you're talking about autism, we encourage you to think about using neutral terminology as much as possible, but also when possible, thinking about the strengths that a person has or that a group of people have, and also kind of leading with that. So these are going to be things like talking about the empathy gap would be an example of a deficit-led terminology or generalization. Whenever you're talking about deficient or deficiencies, especially when you're talking about subject matter that is subjective. So the way that a person expresses emotion or the way that a person engages with a group of other people. A lot of these things kind of feel very, very objective, but when you broaden them and look at other cultural contexts, they aren't actually. So an example of this might be eye contact. As I hope that you guys are aware, in some cultures, it is not polite to make eye contact, especially when talking to somebody that is above kind of your social station, somebody that is older than you, somebody who you're supposed to be demonstrating respect to. You would not make eye contact with them. And so when we're talking about the way that autistic people do or don't make eye contact, it might not be appropriate to talk about it as a deficiency or a struggle or a challenge with eye contact. It might just be something that we can kind of frame as more value neutral rather than something that is a problem inherent to the person. The strengths-led approach is really common in a lot of other academic spheres to support kind of positive overall outcomes. Education is a great example of this, but also kind of other realms of psychology and kind of medicine as well. And what we really want to kind of encourage you guys to do is think when you are doing your research and when you are writing about the research that you do, is focusing on the agency and the humanity of autistic people as a given. Thinking about the ways in which the descriptions of autistic people in your work, might inadvertently kind of view them as, as lesser or as, not fully capable of agency. Autism is not at its core a deficit to be remedied. It's simply kind of a condition or a way of being or a neurotype that some people have and some people don't. And thinking about it in a value neutral way or a strengths-led way can really help develop, better outcomes for individuals. Kind of intimate one-on-one kind of clinician to patient level, but also kind of more generally in society. And last but not least, participant. When we are talking about the people that are working with you in your studies or that are working with you in a focus group, these people are not patients. They are participants. The only time that somebody would be correctly referred to as a patient is if they and everybody else in your study is referred to you via a clinician. Then it might be very accurate to describe them as a patient, and that's what you should do. But just because somebody is in a research study does not mean they are a patient. An autistic person is a patient when they are under the care of a doctor or clinician. So please avoid using descriptors that are inherently medicalized. Patient, PPIE, healthy control, autistic symptoms rather than autistic traits. These are all going to be things that that we're wanting to avoid and think about when they are and when they are not appropriate to use. So I'm going to turn it over to Molly, but first I want to just flag for you guys the recommended resources we have. When I say a lot, we have a lot that is available to you. So please, of course, email me if you are interested in getting kind of the full version of this. And final thing I want to leave you with is a big thank you to all of the collaborators within the autistic community who help us every day to improve our practice at AIMSU Trials. We could not be more thankful, and I hope that you guys appreciate the time and the effort that they are giving to you in helping with all of that. So thank you so much, and I'm happy to answer questions.